From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology web editor. On today's episode, we are discussing dementia risk and disadvantaged neighborhoods. I'm joined today by Dr. Kristine Yaffe. Dr. Yaffe is the Scola Endowed Chair and Vice Chair, Professor of Psychiatry, Neurology, and Epidemiology, as well as Director of the Center for Population and Brain Health at the University of California, San Francisco. She's also a physician at the San Francisco VA. Welcome to the podcast, Dr. Yaffe.
Good morning, Dr. Armand. Nice to be here.
Great. Nice to have you with me. And I wanted to start out with you telling us a little bit about your journey into this topic of dementia risk in disadvantaged neighborhoods.
So we all know that dementia is on the rise as we are living longer and as many of the demographic shifts in this country and in other countries are accelerating the proportion of the population that's older, in other words, older 65, et cetera. We know that dementia is on the rise. And when I say dementia, that includes things like Alzheimer's disease, vascular dementia, and a range of things now commonly referred to as Alzheimer's disease and related dementias. In this case, I'll probably just use the term dementia, but it encompasses all those different diagnoses, predominantly vascular and Alzheimer's, of course. And so because of this rise in dementia, and because it has such an impact on people's lives and their caregivers' lives and the population in general, the cost, et cetera, we really want to try and figure out what we can do about this, ideally to prevent, but certainly to have better treatments and more effective care. And one of the things that we've become very interested in is how somebody's background, their social exposome, if you will, factors like income, socioeconomic status, quality of education, even discrimination, stress, etc., all of these factors might somehow make the brain more vulnerable to getting dementia. And so that was sort of the premise of this study. Could we understand using this very interesting index called the Area Deprivation Index, which is a measurement of about 17 different factors that go into where somebody lives and the quality or what's accompanying where they live. So we wanted to see if that could be linked to one's risk of developing dementia.
Right. Yeah, that's very interesting. I mean, I also subspecialize in headache medicine, and there are certain theories that we discuss when it comes to this. We talk about social causation, in which factors associated with low income could cause an increase of burden of disease. And then there's this social selection, where the illness that the person has makes them susceptible to reduction of their occupational function and therefore causes their low income. And then that can, again, make them more susceptible to the disease that they have and not as good as health outcomes as someone else. Is that something that has been looked into when it comes to dementia and your work?
Yeah, it's an interesting point. When we do our studies of risk of dementia or incidence, we try as best we can often to exclude those who have prevalent cases because of this very same issue. It's very difficult. In observational work, it's always hard to try and tease out cause and effect. But in particular, I think with a chronic illness, that could affect one's memory and cognition. So we usually try and exclude prevalent cases. That doesn't mean you're going to be able to account for all the subtle changes, but at least those with the diagnosis we usually try and exclude so we can try and get at a more unidirectional association.
Mm-hmm. Now, tell us a little bit about the study design. And I wanted to get a little bit more information about what components contribute to the area level deprivation index. You refer to it in your paper as ADI.
One of the reasons we wanted to study veterans and use the VA national data. So the VA has had the electronic health records for years and years, for several decades. They were really ahead of the curve in many ways. And so we have the incredible opportunity to look at several decades of EHR data that's in a repository. And so one of the reasons we wanted to use the VA data to get at this question was, number one, the VA is a national healthcare organization. It's the largest integrated healthcare organization in the world. So we could really get at this in terms of a national representation. The second reason we thought using the VA data would be really compelling was that one of the challenges when you're looking at some of these social determinants of health factors and trying to look at outcomes, regardless of what the outcome is, you don't know how much could be related to access to care.
Right.
How much of this could be that people just don't have health insurance or don't have a nearby doctor, et cetera. The nice thing about the VA is everyone has access to care. One could argue it may not be equal, and there certainly could be regional differences in terms of access, but theoretically anyway, everybody has this health insurance and access to a VA or to a partner funded by the VA. So that was another compelling reason why we thought this would be a really good group to study. The other thing is that the VA is fairly diverse now. People who are entering the military are diverse, and of course then veterans are diverse, and we wanted to really look at that as well. Not to have some rarefied university-based setting where there wasn't a lot of variance in area deprivation index, if you will. So that was the premise. Why the VA and why look at this in a national population, which was diverse, which had a lot of difference in area deprivation. So a lot of this work has been led by the University of Wisconsin-Madison, Dr. Amy Kind and some of her colleagues. And what this is it's basically an index that was developed by the HRSA administration a while ago and then refined by the Wisconsin group. And so what it is a way to link where somebody lives. And in this case, we use the zip code, which then is linked to the census tract. And then we were able to use the Area Deprivation Index Atlas, which is at the University of Wisconsin-Madison. And by the way, is free for people to download. So that link enabled us to obtain an ADI for each of our participants in our study. The ADI, in turn, is a rubric of about 17 different measures of one's deprivation, if you will, where they live. So it encompasses things like housing quality, education, income, etc. Some things aren't there. We don't have pollution, for example, but it really gives a good level of what somebody exposed to where they're living, what kind of resources do they have, what's the quality of the housing, etc. So it's a really nice composite. And the higher the index, the more suggestion of a neighborhood deprivation. The higher the marker, the higher the deprivation.
Got it. Got it. What was your population size out of this VA cohort?
So what we do is we're using this VA national data, and we take a random sample every year, and then we merge them. And of course, if there's duplicate participants, we figure that all out. And we require people to have at least one follow-up visit, because sometimes people are just seen once, and obviously then we couldn't really ascertain who went on to develop dementia. So we required the veterans to have been seen by the VA. We randomly selected them and then required some sort of follow-up so we could ascertain dementia. These were all using ICD codes from the electronic health records. And so our population for this study ended up being about a little more than 1.6 million veterans. And again, one of the advantages is that these are people all over the country, and they were quite diverse in terms of representation. Not so many women, not surprisingly. So that is a limitation of our study, is that because it's veterans, it's much more men, of course.
Now, before we get into your results, we do know that there are risk factors for dementia, different types of dementia. And what sort of confounders did you account for in this study?
Yeah, well, that's always a challenge, isn't it, when you do. observational work. And again, one of the nice things about this VA national data is we have all of these medical and psychiatric and different factors. It's not super granular, so we can't say always a lot as much as we'd like, but we had very good measures of cardiovascular risk factors, cardiovascular disease, which of course is always an important confound, particularly when you're looking at social determinants of health. We know there are very big links with cardiovascular disease, and cardiovascular disease in turn is a very important risk factor mechanism probably for both vascular dementia, but also Alzheimer's, which is something people don't always realize. And so it was very important for us to take into account cardiovascular disease and cardiovascular risk factors, such things as diabetes, hypertension. We also were able to take into account a lot of psychiatric comorbidities, such as depression, PTSD, these other factors that we have found to be associated with dementia risk. So we tried to adjust for anything that we thought could be a confounder. Of course, it's not perfect because we are using ICD codes, but we were able to really, with these large numbers, account for a lot of different psychiatric and medical comorbidities.
Mm-hmm. Yeah, tell us about what you found.
So first of all, what we found, and we were quite pleased in the sense of a study design, was that the area deprivation index really did show the very large gamut. It was really a nice kind of normal distribution, which you don't always see if you're looking at a selected population in maybe one small area or one university-based clinic. So we were pleased that we could see a wide range of area deprivation index as our predictor. And then what we did was we divvied the population up into quintiles. We do that for ease of analytic strategy, but also because it gives somewhat of a meaningful marker of what the deprivation index can be translated into. And so we then looked at how the quintile of ADI was then associated with risk of dementia over, we had about a mean follow-up of 11 years, but there was a range. And what we found was that in actually quite a linear fashion, that those in the higher area deprivation index, those veterans who had been living in an area which would be qualified as the most deprivation areas, had a much higher rate of developing dementia compared to those in the lowest. But for every quintile of higher deprivation, we saw really this sort of graded increased risk. And as you know, it's not perfect for causation, but it certainly does help us think this might really be a causal association, given this sort of graded dose effect, if you will. And then I would say, back to one of your questions, so then what we did was we adjusted for all the possible confounders, and it really remained fairly robust. There were some small changes in the effect size, but really still remained quite high. And also, we then accounted for competing risk of death, which is also something that's important given that there's a very clear association with area deprivation and risk of mortality, and that could introduce a bias. So we did also do models adjusting for mortality, risk of death, and again, the results remained quite robust.
So that's very telling of what we've been seeing in various medical illnesses and ailments, and we're seeing this in dementia as well. Where do we go from here? What would you say is the next best steps in tackling this and working toward prevention, right? Because that's important with neurodegenerative diseases.
I couldn't agree more. One of the really, really important pieces here, I think, is quality of education. And I think one of the most important things is we really need to make sure our public schools have as much funding as possible and the quality of education, because we know that it just isn't an equal playing field. And education, we know, is really, really tied to risk of dementia. Why? We don't know exactly why. It's a really fascinating set of reasons, probably. But one of them is this concept of cognitive reserve, this idea that if you can somehow have greater education or greater brain power from a variety of reasons, this is almost a buffer against developing dementia. And it's a really interesting theoretical framework, but now is really sort of bearing out. So that would be one thing that I think we could do that actually would have a big effect on risk of dementia. Other things are also challenging, but extremely important. Obviously, we don't want to have such discrepancies with where people are living and the amount of stress and poor quality housing and access to healthy food and green space and on it goes.
Right.
So I think it's hard because these are some of the real challenges of our country and many other countries, how to make life and where one is living more equal.
Right.
But I think it certainly suggests that some of these social determinants are very important in, as you mentioned, many health outcomes, but we're seeing it certainly in dementia risk as well.
So we're talking here, identifying it, taking a good social history, making sure you understand what challenges the patient has, and education from the beginning, from the ground up, is important, and funding, right? Because it's not just at the physician level, at the individual level, it's also way higher up in order to help with this as well.
Absolutely. Absolutely. When I sometimes give talks about prevention and people say, well, what's the one thing you could do? I would say it's really getting at these fundamental issues, and particularly around education. And I think just having a background that's not filled with stress and uncertainty and challenges around just getting by in life.
Dr. Yaffe, I want to thank you so much for joining us today.
It was really my pleasure, Dr. Armand.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This is Dr. Cynthia Armand. Thank you for listening.